And any question from the online audience, you're welcome to sending the questions through the Q&A section. Dr. Lee, are you back?
Yes, I am.
Okay, so I have a question for you. So you talk about immunotherapy and then combined with SRS. There are some data showing that radiation now can induce the immune infiltration of the immune cells. And do you think if we do SRS prior to immunotherapy would be better than immunotherapy prior to radiation or concurrent?
Yeah, that is an excellent question. I think that's the question that have been on our mind probably for the last few years. And there are different explanations, different rationales for doing one versus the other. I think as for now, I truly don't know what the answer. One rationale could be, when you give radiation first, you release tumor antigen, and then you give your immunotherapy to boost those clones of the T cells. So the other argument is that you can boost the clones when you have the tumor there. So I'm not quite sure I know the answer to that one in terms of sequencing. I think there are multiple, quite a few publications with contradicting results. I think some results will show that if you do radiation first is better. Some will show that if you add immunotherapy first, it's better. So in our practice, particularly for our trial, we typically do radiation first, like especially if it's SRS, because it takes just one day to treat those patients. So we treat them and then we start immunotherapy within that same week.
Thank you. So the next question is for Dr. Kazar. Do you think if in any time we do the radiation first and you still can do the surgery? Because the reason I ask that question is that a lot of time after the surgery, we have a lot of metal stuff there. And we cannot do MRI. It's very hard for us to do SRS, basically impossible. So I just always thought, it's possible that if we have done the radiation and then you do surgery, still possible or not?
Yes, great question. So yes, we rather not to have conventional radiation before surgery, because then the surgery is, the wound healing will be very problematic. In that case, the skin is tough and the healing is not that well, but there is no problem in delivering SRS before surgery. And if we need, then to proceed with surgery. Regarding the artifacts after the instrumentation, after the surgery, I showed you what we are doing currently with the carbon fiber instrumentation, which will reduce substantially the artifacts shown on the MRI and on the CTs. But what we are doing, what we can do if we are not using the carbon fiber instrumentations, we're just performing a CT myelogram. And by that, fusing it to the preoperative MRI, we can plan the radiation with a good rate of success.
Thank you. Any other question from the audience? Oh yeah, Dr. Zhang.
You can get this work. Actually, I have 3 questions for Dr. Lee. This is Cancer Radiation Oncology. Thank you, Dr. Lee, for such a nice presentation. So my first question is regarding SRS versus surgery. Now, we have done so many trials on SRS, And we have trials on surgery. Now we have trials on surgery followed by surgical cavity radiation, either with SRS or whole brain radiation therapy. Now, looking at the trial you just presented, that the pre and post surgery SRS treatment. My first question is now looking at that study. Now, once resected, the rest unresected disease, then we'll treat with SRS, which means we already accept SRS alone is adequate treatment for unresected metastatic disease. So if that's the case, why can we design a trial just to answer that question? Whether we really need surgical resection versus SRS alone will be as good or maybe even better than surgery. So that's my first question. I can answer second.
Can I address your first question first? Hello?
Yes, please.
Oh, okay. Yeah, so that's an excellent question. Actually, in our practice, if a tumor does not need to be resected, we don't resect them. So our surgeons only will resect the tumor that's a large or the tumor that are causing symptoms. So majority of the brain mets are treated with radiation first. And then if they progress after radiation, then we can consider surgery. But surgery is only used in selected cases where like large tumor patient symptomatic. So it's a very quick way of relieving the pressure in the brain.
Thank you. My second question is regarding that study that you presented, several studies looking at a single dose SRS versus fractionated SRS. So apparently the patients that treated with SRS, single dose radiosurgery, did worse compared to the patient who received fractionated SRS. It looks like 60% versus 80%. So my question actually in practice, we always face the same problem. That is, one had SRS. You see necrosis, you wonder that's progression or pseudo progression or radiation necrosis. So I just wonder the patient who received a single dose SRS probably had a higher risk or likelihood of radiation necrosis, not true progression, as opposed to the patient received fractionated SRS. So that's my second question. Yeah.
Yeah, I agree. I think the tumoricidal dose, the biological tumoricidal dose, is probably very similar among those different regimens. But the effect on the soft tissue, on the normal tissue is a bit different. So I agree with you that I think the risk with single fraction for developing radiation necrosis is probably higher. So your question is that, the comparison slide that I showed, could part of that perceived as local recurrence is due to radiation necrosis? That's very likely. That's very likely. But we don't know the answers. We really don't know. So I think that's why I think, we will find out from that prospective study, the Alliance study, and I'm sure they will, try their best to differentiate between tumor necrosis and progression.
So in your practice, are you moving away from a single dose SRS now?
No. So we still pretty much go by the size. So for small cavity or small tumor, we do single fraction. And then for larger cavity or a larger tumor, we use fractionated treatment, or tumor that's close to critical structures. However, I have to say, because of the publication of the NCCTG showing that SRS arm had higher recurrence, I tend to do a little bit more in the post-op setting using LINAC-based SIS treatment. So we basically, we have, we have Gamma Knife and we have LINAC based. And, but for cavity, now I tend to use LINAC based treatment for 3 to 5 fractions. The reason is that with LINAC based planning, the dose fall off outside your target is not as sharp as Gamma Knife. So you get a little bit of that lower dose bathing of the surrounding area. And secondly, also with LINAC-based treatment, we typically add a little bit PTV margin, so we can cover a little bit more. So that's a little bit of change that we've been doing, because I'm really concerned about, missing the target with very, very sharp dose fall from Gamma Knife treatment. But to answer your question, we are not moving away from single fraction. Our decision making is still mostly based on the size and critical normal structures that are close by.
Thank you. My last question is re-irradiation. So in what situation you would consider re-irradiation with the patient who failed stereotactic and re-irradiation in those patients?
That is a very, very good question. When you say fail, meaning you have evidence to show that it's a tumor recurrence instead of radiation necrosis.
That's correct, yeah.
Okay. We have done a little bit more now. There is a publication from Utah years back showing that there is about 22% risk of radiation necrosis when you treat with SIS. So we do not do it routinely. So I can give you some examples of the cases that we radiate. So typically it's a tumor, like a relatively larger tumor that we treat with single fraction, and the patient was doing well for a while, and then the area started to enlarge. And then we do our imaging studies. We tend to do perfusion scan, we do MR spectroscopy, we do delayed PET. With all those studies, if the results still point toward tumor recurrence, so the first approach we try to take is resection. So we're trying to talk to our neurosurgeons, see if there's any way they can take it out. If they take it out, and if the pathology is mostly tumor, we sometimes follow up with 3 fraction treatment, 3 to 5 fraction treatment, depending on the interval from the last radiation. So if they don't take it out, our neurosurgeons also do a laser ablation where they put a needle and heat up the center of the tumor. That is a treatment mostly for radiation necrosis, but they also use it for residual tumor that at a location that's not resectable. And they have about 83% success rate with that approach. But again, it depends on the shape of the tumor and the location. So if it's a solid tumor, we haven't really done re-radiation. So maybe we should have a trial to evaluate that. And I believe there is a patient population that our hands are very tight.
Yeah, it's always difficult because in practice, we see those patients had SRS, but we suspect patient has recurrence, but either patient refused the surgery or surgery cannot be done. So in those situations, we kind of forced to consider re-irradiation. So it can be very difficult.
Right, right. Yeah, I think, as long as you explain the risk to the patient, you have exhausted, all the discussions, all the other options, as long as patient can accept the risk, it's probably okay. But we don't really do it. We hardly do it. But for the resected cavity, sometimes we do it. So, especially if the pathology is consistent with tumor. Thank you.
So next question from Dr. Kevin.
All right, hi, Dr. Lee. Again, thank you very much for doing the talk today for us. So I think I want to follow up with Dr. Zhang's question on the tumor cavity. It's probably more a practical question. So I know you're a little more generous. I mean, I'm doing the same thing too, but what in general do you expand along the dural at the edge of the cavity?
Oh, yeah. So actually, the pattern of recurrence in the surgical cavity is mostly dural-based, right? So we do, so we use both the pre-op and the post-op scans, because if a tumor does not really involving dural at the beginning, its risk of coming back there is probably not very high. But if a tumor has dural involvement pre-op, then we try to really identify the area and make sure all is covered. I like to have about 5 millimeter margin on the dural at least. And if we do LINAC based, this is not the reason that I tend to use LINAC based approach now, mainly because I can easily follow the dural and I can add a margin, and we also add a PTV margin, so you cover a little bit more.
Another question I have for you is, I think although we don't have that many fractionated, particularly 3 fractionated SRS patient yet, but I do start to see a pattern of much delayed immune reaction or necrosis. Do you feel the same way or different?
You mean for cavity or for solid tumor?
For solid tumor.
I think in my experience, I haven't been able to really clearly detect a difference, but I have to say, I haven't, we haven't looked into our data.
Any other questions? Oh, okay.
So my question is for Dr. Shonka. So how do you see the role of anti-angiogenic therapies in combination with PD-1 when you compare head-to-head with radiation promoting PD-1 responses versus Avastin and Avastin plus radiation therapy?
So really good question. Some of the clinical trials that I kind of had to quickly gloss over in the table are giving patients who are not methylated, who are newly diagnosed, nivolumab or pembrolizumab, along with radiation, and adding Avastin. I believe this is probably being done for 2 reasons. One, we're not quite comfortable saying just because you're methylated, we're not going to give you any other proven medical therapy. And that's part of the reason for Avastin, because these patients aren't receiving temozolomide. The other reason I think behind that is that we can quite often see a lot of inflammation, as the radiation oncologist here will tell you, when we're radiating. And so giving Avastin actually will decrease the likelihood of some of the cerebral edema we stir up with the radiation therapy. And if we can avoid greater than a 4 milligram dose of dexamethasone daily, then you're actually going to be able to probably see a greater response, at least theoretically, to your immune checkpoint inhibitor. Does that answer your question, Manish?
Partly, but another aspect of that is, how does vascular damage or remodeling impact the immune cell trafficking in the tumor, which can actually be a determinant of PD-1 or an immune checkpoint inhibitor responses?
I don't know if anybody knows that answer yet. There have been thoughts that Avastin actually more or less fixes the leaky blood-brain barrier, which is why on imaging we see that the contrast enhancement improves so much. But what we don't see with Avastin, right, is an improvement in survival overall. We just see an improvement in progression-free survival. So I don't know that that's been looked at for certain yet.
Okay, question from Dr. Ken Zhang.
Yeah, I have a question for Kevin. So actually, the one you showed us, I believe that's a mouse model that was very impressive with enzalutamide with the radiation therapy. Now, so how was that given? Is that IV or IP, or how was that given, the dose?
to be convenient for the lab person, we decided to do IP.
So do you know that those will be achievable in human?
So to be honest,
Any other questions? Oh, yeah. Dr.
We have
Sonka?
time. Quick question for Kevin. What about complete androgen blockade?
Kevin, can you press your microphone? We have a remote.
sure. So the nice thing of using those old drugs is that we have so many clinical data previously, and the translational study on prostate cancer. So blocking the testosterone level by complete blockade, adding the Lupron and other drug on top of biglutide has an issue of decreasing the circulating testosterone. And as we know, the androgen receptor has both ligand-dependent and the ligand-independent function. And in the ligand, all the immunomodulating markers actually are functioning through the ligand-independent pathway. So if we suppress the testosterone, we are actually induce the IL-6, FOX, like other IL-6, LIF1 suppression, overexpression. So potentially could like offset the biglutide effect, which is probably why we see so many prostate cancer patients and a lot of trials in checkpoint inhibitor study with those people on complete blockade actually doesn't seem to be very beneficial. So probably I think we should not suppress the testosterone level.
Okay, I think the time is up. We have a 20 minutes break, and we will come back at, what time is it? The next section is prostate cancer, and Dr. Ken Zhang will be the moderator. And what time is it? Okay, we will come back at the 10:20.然后下一个我不在这里。